So every speaker I've seen this morning and throughout this conference have said that it's a great honor to be invited here. And that, I think, goes double for me, because I'm not an immunologist, I'm not a healthcare professional, I'm not a patient representative. I am instead a real, live philosopher. And so I'm in a rather unusual situation of addressing an extremely distinguished audience, all of whom deal with things that philosophers only think about, things like facts and patience and so forth. So, as Bobby said, I am in fact a moral philosopher. That is, I specialize in ethics and morality. Whether or not personally I am in fact a moral philosopher, that's something that's entirely up to debate. I should note that for last weekend, past few days, I've been walking around with the designation medical on my name tag. And when I told my wife and said that this was rather wonderful, she said, that's just horrific. I don't even trust you with aspirin. But what I can be trusted with, I hope, are actually ideas. And I should note, incidentally, for those of you who've read my bio and seen my picture, I look rather different. Because every time I give a talk to non-philosopher audiences, people say, well, are you really a philosopher because you don't have a beard? So I've actually grown a beard just to prove my philosophical credentials. So, what I'm going to address today are 4 particular issues. I should note that these are issues just to start us off. As Bobby said, the aim of this session is really to get a dialogue and a conversation going. And the issues that I'm going to address are, should information about non-PID medical issues be disclosed to patients if discovered in the course of testing for PIDs? Do patients have a right not to know about genetically linked disorders, whether PID or not? Do patients or their healthcare providers have an ethical duty to disclose the results of testing to persons affected by them? What obligations do healthcare providers have to educate patients about what is implied by genetic risk? Now, I'm not going to give you the answers to any of these questions. Instead, what I'm going to do is to outline some of the arguments in favor of positive answers to these questions and some of the arguments in favor of negative answers to them. So that, I hope, will give us a rather nice framework for discussion. But before I begin, I should ask, how many of you have training in analytic philosophy? I take it that's none of you.
I think that's just you, James.
It's just me. So I can say anything and you would believe me. So since people don't have training in analytic philosophy, you've all pursued, if I can put it this way, more useful fields. What I'm going to do is give you, in 3 minutes and 28 seconds, an overview of case-based and analytic philosophical reasoning. With that in hand, we can then move forward onto the particular issues that we're interested in. So here's a quick account of 2 types of ethical reasoning. Firstly, there is theory-driven reasoning. You defend a particular ethical theory, such as utilitarianism, the idea that we should try to maximize the greatest happiness for the greatest number, or Kantian ethics, the idea that we should follow the moral law and respect the dignity of persons. Then, with your theory firmly in hand, you apply it happily to the issues that you're actually addressing. So an example of this, and it seems natural in clinical practice, might be taken from Dr. Andrew Kent's talk earlier this morning, where he said what we should do is balance the risks and benefits of certain types of therapies. That, for a philosopher, is a straightforward utilitarian approach to a particular ethical issue. Alternatively, you might have case-based reasoning. You identify certain morally relevant values: autonomy, beneficence, justice. Then you identify a particular case, either real or imagined, that is relevant in similar respects to the actual issue that you are addressing, and where respect for the values that you have identified leads clearly to a particular conclusion. So, in other words, you reason by analogy. You adopt a case, you see where a good ethical approach would take you in that particular case, be it real or fictitious, and then you apply that same reasoning to the actual case that you have in hand. Philosophers often like case-based reasoning because you can narrow things down. You can construct cases where you can just focus on particular salient issues and you don't have all the noise of real cases. Then you can make particular decisions and apply them to real cases. These approaches both have pros and cons. Theory-driven reasoning has a definite pro. It often gives you a very clear and ready answer. If you're a utilitarian, you want to know, what should I do in this particular case? Should I disclose to my patient that she's at risk for a particular genetic mutation? If it will maximize overall well-being, the answer is clear. Yes, you do. The problem, however, is that your theory might actually be wrong. And moreover, it won't be accepted by everyone. This, incidentally, is something that I think philosophers often overlook. You frequently have somebody who self-identifies as a utilitarian, or a Kantian, or a natural law ethicist, and then they say, here's the correct answer, and they apply it. That's why when Bobby said, are you a bioethicist? I said, no, I prefer to think of myself as a moral philosopher, because at least in the American context, bioethicists tend to be the people who appear on radio and television and in newspapers telling you what to do and what to think, because they've endorsed a particular ethical view and they're going to apply it, come what may. Case-based reasoning, however, can be very sensitive to particular aspects of each individual case. Moreover, you can learn from cases as you go along. It's my understanding from working with clinicians that a lot of healthcare professionals do this. You have a particular case, you identify the underlying cause of the disease or the pathology, and then you find similar cases which might slightly differ. You then draw on your previous experience to help you make diagnoses. So case-based reasoning, I think, is useful in medicine, and it seems to be how the Anglo-American common law tradition progresses as well. But it does have a disadvantage. You might have a case where it's very difficult to see how an analogy can be developed, which is very different from any other cases that you've encountered before. What do you do then? It's not clear if you're using case-based ethical reasoning. So, here we have theory-driven reasoning and case-based reasoning. I prefer case-based reasoning. I think it's more nuanced, I think it's more sophisticated, I think it's more helpful. It is also, I think, a much more humble approach to take. So, one of the presenters this morning noted that sometimes you might actually be wrong about things. You should engage in dialogue within the academy and discuss things with your peers to find out where you're mistaken. I have a confession to make. Some of my most deeply held beliefs I know are wrong. The trouble is, I don't know which of my deeply held beliefs are wrong. If I did, I wouldn't actually continue to hold them. So case-based reasoning and discussion, I think, is really useful for winnowing out false ideas. And I was extremely pleased to see the presenter this morning note that he had been mistaken in the past, and now we've got a better and more correct view. That's wonderful. So how does case-based reasoning progress? Here I should give you a warning, since I don't have any philosophers in the room, that philosophers like to construct deeply bizarre examples. Philosophers' articles are replete with discussions of green slime, the fat man in the mouth of a cave, the trolley problem, the violinist case. None of them bear any relevance on the face of it to reality. But the idea is to try to winnow out particular ethical principles from very bizarre cases. Then we can take those ethical principles and apply them to the real world. I'm spending time on this because some of the examples that I'll give later seem not to be related immediately to PIDs and genetic testing, but as the conversation progresses, I hope their relevance will become immediate. So I'm going to give you a couple of very famous examples which have generated whole industries amongst philosophers. Judith Jardiff Thompson's violinist example and Peter Singer's baby in the wading pool example. Neither of these, I must stress, are related to PIDs. I'm using them instead to show how case-based reasoning can progress and to sort of take away some of the oddity and the mystery of it. Judith Jardiff Thompson's violinist example is one of the most famous examples in philosophy. It's extremely important. It's an example that occurs in the context of the abortion debate. Judith Jardiff Thompson's example runs like this. You wake up one morning, and I'm going to ask for a volunteer shortly. You wake up one morning and you discover yourself attached to a concert violinist who's using your kidneys and your organs to remain alive. The Society of Music Lovers say you have to remain attached to the violinist for 9 months. Now we've got a question, and I'm going to pick on somebody. I'm going to pick on Josie. Josie, do you think that you have to remain attached to the violinist for 9 months? Or could you unplug yourself knowing that this will result in the certain death of that person? Now, when students say that, I often say, pick somebody else. And they hate that.
Go on.
Well, I think I would stay attached.
You would stay attached. Would you believe that you have to stay attached?
No, I don't know.
Wonderful. So you might say, you don't have to stay attached. Notice that Thompson now says, if you claim you do not have to stay attached, then remember the violinist is attached to you for 9 months. In cases of involuntary pregnancy, even if you grant full moral status to the fetus, abortion might be morally permissible. Then the examples unfold and we move further into the debate. But notice what Thompson does. You take an example which is unrelated to the abortion issue, you narrow it down, you identify a particular principle, see if we can gain consensus, and then move forward. Peter Singer's baby in the wading pool example is similarly unrealistic, but also similarly important. So you're walking along and you see a baby in a wading pool, face down, the poor child is drowning. How many of you believe that you should reach in, ruining your new shirt, and flip the baby over? Just a quick show of hands. Of course. Everybody thinks you have to save the baby. Now notice what you've told me. You have to sacrifice something of little moral importance, your new favorite shirt, to save a life. Wonderful, says Peter Singer, because my article is entitled Famine, Affluence, and Morality. Do you have to sacrifice something of limited moral importance, your new bottle of designer water, which I see people around here sipping happily, and donate that money to famine relief? If your claim is you have to save a baby, even at the expense of your new shirt, Singer's claim is you're on the hook for many moral obligations concerning the poor, the starving, and the hungry. And then again, now the conversation starts unfolding. So we start off with cases which appear not to bear much resemblance to the issue at hand, and then we move to apply them. So now let's turn to the real things that we're actually interested in and the people are actually here for, which is ethical issues to do with genetic testing and PIDs. Before I begin, however, notice that we do have various central values in contemporary medical ethics. Respect for autonomy, that is, a respect for people making their own decisions. And in Siobhan Burns' presentation this morning, we saw a beautiful example of that, where we move from paternalism to negotiated choice, and where patients' interests are more central than they were in Ireland some 30 years ago. Beneficence, a concern for the well-being of persons. Non-maleficence, basically you don't be mean to your patients. And justice, how do we distribute healthcare resources accurately and equitably? So let's turn to some of the issues. One of them is a disclosure of non-PID issues. So we do genetic sequencing. We discover that a person has non-PID genetic susceptibility. Maybe they're susceptible for breast cancer. Maybe they're susceptible for Huntington's. Are we required as healthcare professionals, that is, when I say we, I mean are the healthcare professionals in the room required to disclose this to the patient? On the one hand, you might say yes. After all, if you don't disclose this issue to your patient, you're withholding from them information that they would need to make informed choices about both their medical care and their future life options. Moreover, if you withhold the information that you have, you might be adversely affecting the person's life. If they know this, they can make informed decisions about their medical care. If they don't, they can't. So we might argue, yes, you are actually morally required to make disclosure of genetic information that you discover accidentally, as it were, to your patients. But that's not the only position that we could take. Somebody might say, no. Patients might prefer not to know about additional genetic risks. Informing patients could compromise their well-being and adversely affect the instrumental value of their autonomy. That is, their ability to guide and direct their lives to achieve what they consider to be a good and valuable life. Moreover, you might argue, if you're a healthcare provider and you've contracted with a patient or a patient's insurance company to do genetic testing for PIDs, then it seems that that's your only obligation. You have no further ethical obligation to disclose anything else which might have been turned up by your particular investigations. So if you haven't discussed this with your patient, then the argument is disclosure is not ethically required. So on the one hand, we have arguments that say yes, you are required to disclose. On the other, we have arguments, no, you are not required to disclose. What about the right not to know? Notice that in the former argument where we argued that you should not disclose, we noted that some patients might not want to know about genetic susceptibility to non-PID diseases. Some patients might not want to know for good reason. Here's a very simple example. In the very first session on Wednesday evening, I came in a little bit late and was standing at the back along with about a dozen other miscreants. And the very helpful presenter informed us of something that we didn't know, namely that there are chairs at the front. And I looked along the row, and everybody, including myself, was feeling very awkward. On one hand, there were chairs at the front, and we might like to sit down. On the other hand, we would have to walk embarrassingly down the center, exposing ourselves to the sight of everybody who turned up on time. So I knew, is anybody who here today was in that situation with me? Yes, I see some people nodding. So there we might have preferred not to know that there were chairs at the front. That's a trivial example. Now imagine a more worrying example. Imagine that it has now been disclosed in the course of investigation for a PID that somebody is at risk for Huntington's or for breast cancer. I can imagine a patient not wanting to know that particular piece of genetic information. They might be somebody who tends to be extremely anxious, and they might say, and say reasonably, I would strongly prefer not to know that I was at risk for breast cancer. I would like to live my life without knowing the shadow of Huntington's hung over it. So you might say, patients do actually have a right not to know. Imagine, moreover, if you might be a carrier for a PID, but you won't actually instantiate it yourself. Say, you're a family which has Bruton's disease, which I believe is an X-linked disease, and you might have carriers who are sisters of the boys who exhibit this, or for maternal aunts. Those persons might say, I might be a carrier, but I would prefer not to know this. I might feel an ethical obligation to disclose it to people. For example, if I'm going to have a sexual relationship with them. And that might mean that my options will start to be limited. Or I might be concerned because I have mistaken ideas about what it means to have genetic defects. People might not want to know either about non-PID genetic defects or PID genetic defects. Concern for their well-being and autonomy might mean you ought to respect that right. However, we could say, look, a person's health status is not just a concern to her. It also affects her family members. Hence, the decision not to know should not simply be an individual decision. It should be a decision that patients make with their families, with their healthcare providers. We might also argue more strongly. If persons have particular genetic defects which could be inherited, then they should be told this, and they should perhaps have the obligation to disclose ethically. Again, we have arguments on both sides of this issue. Do patients have a duty to disclose? You might say yes. If you know that you have a particular genetic defect, then you ought to disclose this to persons whom it might also affect, not merely family members or friends, but perhaps also life insurance companies might have a right to know certain facts about you. So maybe we could argue patients do have an ethical duty to disclose about their genetic status, be it for PIDs or elsewhere, other diseases. Alternatively, you might not have a duty to disclose. Perhaps the person to whom you are considering disclosing has a right not to know, and they wish to exercise that right. What about the obligation to educate on the part of healthcare professionals? The argument in favor of this might seem straightforward. If you know that somebody has a particular genetic defect or is about to undergo genetic testing, maybe you should educate precisely what this entails. dispelling common myths. If you have a genetic defect, is this automatically inheritable? The answer seems to be no. Patients should know this. If you have a genetic defect, does this automatically mean you will develop the disease? For some defects, the answer might be no. What does it mean to have a genetic risk? These are things that patients should be educated in, you might argue. A concern for patients making informed decisions means they need to know this information. A concern to allay possibly misplaced worries and concerns can be done through education. So we have a duty to educate patients. Alternatively, somebody might say no, because notice that a concern for education is going to take up resources. There are opportunity costs associated with hiring geneticists, with hiring counselors. Those of you, I'm looking over the audience, and I can pretty much guarantee that everybody has had some opportunity costs for attending this conference. If you're a healthcare professional or a patient or you're a researcher, your opportunity costs are fairly high. Your opportunity costs in economics and philosophy is the value of the thing that you gave up to do something else. So if you gave up doing research to come to attend this conference, then your opportunity cost is the value to you and to others of that missed research that you gave up. If you're a patient representative, your opportunity cost, if you came here without your family, is time away from your family. So it's costly to attend this conference. I can see everybody here probably has much higher opportunity costs than I. For me as a philosopher, I have limited opportunity costs. When Johan invited me, my formal official response was, I would be delighted if my current commitments allow. My actual response was 3 days in Budapest. Yes, of course. This would be wonderful, and I'll learn so much about genetics. This is marvelous. Very low opportunity costs for me. But notice, if you're a hospital, you're going to incur costs hiring geneticists, hiring counselors. We have finite medical resources. Maybe somebody might argue those resources could be better placed hiring researchers, hiring people not to counsel patients, but instead to actually deal with patients. Not hiring a geneticist to counsel patients, but instead hiring more nurses to deal with patients. Education comes at a cost. So somebody might argue a concern for the appropriate allocation of medical resources should militate against education, not in favor of it. So, thank you very much for listening to me. Hopefully this has been instructive, and I very much look forward to your questions. And let the conversation begin. Thank you.